Audible.
Okay. Dear darling Madam, Gigi Madam, who is the mentor for this today's session, and respected senior faculty members, Purushottam sir, Shanavas sir. So this time we are having the second program of IAP PG Club from Kottayam for the year, this year. And this is a wonderful program, and I think most of the postgraduates are utilizing it maximum. And it's a wonderful platform where you can share your information with different faculty from throughout Kerala are becoming part of this program. And I request Joe sir to give the introductory remarks.
Thank you, Dr. Suresh. And respected today the faculty, the Professor Savitha Madam, the Professor Darli Madam, and today the Professor Shanavas sir, today the mentor Dr. Gigi, and the senior Professor Dr. Purushottam sir, today the presenter Dr. Chinnu from ICH Kottayam. My dear, all the senior members and postgrad students. As Dr. Suresh is mentioned, this is a platform for discussing the common cases in your day clinical practice, how to approach a case scenario by the different faculties all over Kerala and outside Kerala. We are planning to conduct the program. I think this program is it's well utilized by the PG students all over India, all over Kerala. I think that was very useful for all the teaching program, was very useful for the practicing pediatrician also, for how to approach a case and how to discuss what are things to be in mind before taking a case to discuss for day-to-day practice. I think the whole program is IAP Kottayam. It's under banner of IAP Kerala and joint venture of IAP Kerala. Dr. Shanavas, the state convener of this program, he is doing a number of jobs coordinating all this program every Thursday, 7:30 p.m. with different IAP branches conducting the Shanavas sir. Congrats Shanavas sir for all the support for this program. Again, IAP Kottayam. Dr. Murari, Dr. Anush, and Dr. Manu is doing a wonderful
conversion.
So I wish you all the best program. Jai Hind, Jai AP.
Okay.
I request Darli Madam to give introductory remarks.
Good evening, everyone. I am not taking much of the time of this PG club. Wish you all the best for the Chinnu, and also the discussion is our Savitha Madam. Anyway, that will be a good discussion on the this particular case, that I am sure, and wish you all the best. Thank you.
Suresh Mutana, unmuti, Suresh unmuti.
Shanavas sir, please.
Very good evening to all. Respected Joe sir, Savitha Madam, Purushottam sir. I am also not taking much time, so her PG program is going on very well, and each region is very much enthusiastically participating. And before I am asking, this is your turn. Everybody is ready with the cases and chairperson like that. So I think the PGs are also utilizing this very effectively, and I wish all the best for the program. Thank you, IAP Kottayam, for conducting this program this time. Thank you.
Chinu, before we go on to the program, can you give the name of other PGs available with you who will be helping you with the discussions?
Sir,
Who are how logged in?
Sharanya, Dunya, Rahul.
Okay, Sharanya, Dunya, and Rahul, Madam. 3 of them are there. More of them will be helping here also. And Joseph will start directly go into the session. Gigi Madam, you want to say something? You have been the mentor of this today's session. Gigi Madam?
Yeah, nothing.
Okay, Madam. We will start the session. Over to you, Savitha Madam, for the session. And Chinnu, you can start the screen sharing. And you are now muted. You unmute yourself and start the session. Madam, Savitha Madam also is muted.
Unmute,
please
madam.
Unmute and
Savitha Madam, unmute.
Madam, you can unmute.
Hello.
Okay,
Am I audible?
Okay,
Clear.
audible.
Okay. So thank you, IAPN. for giving me the opportunity. Today is a very interesting case and a problem case. And I expect contributions from all the audience because this is a difficult case.
ശബ്ദം ലോഗിൻ ചെയ്തിട്ടുണ്ടോ മാഡം?
എങ്ങനെ?
2 ഡിവൈസിൽ ലോഗിൻ ചെയ്തിട്ടുണ്ടോ? ചെറിയൊരു
ഇല്ല.
ശബ്ദത്തിൽ ഒന്നൊരു ക്ലാരിറ്റി കുറവുണ്ട്. എന്തോ
ക്ലാരിറ്റി കുറവാണോ?
എന്തോ ഒരു ഡിസ്റ്റർബൻസ് ഉള്ള പോലെ തോന്നുന്നു. കണ്ടിന്യൂ.
Continue, madam.
Okay. So over to Chinnu. Present the case. What are the complaints? Chinnu?
Madam.
Yes. Present the case.
Good afternoon. I'm presenting a case of 9-year-old boy, who is hailing from Paika, Pala, presented with complaints of tiredness 3 days, pale appearance for 3 days duration. History of presenting illness. Child is a known case of some hematological disorder since 5 years of age, for which he was treated on and off oral iron therapy whenever he has low hemoglobin was detected, with improvement on hematological parameters to normal value with the treatment, and now complains of tiredness and paleness of palm and skin for 3 days duration. Mother noticed that he was not interested to do any activities as usual, and he likes to remain in bed for the last 3 days, and history of associated increased sleepiness was present. Normally, the child eats very little food, but now the child food intake further decreased due to decreased appetite. So they consulted at local hospital on the 3rd day of illness, and the blood counts were done, and he was found to have low hemoglobin, and the child got referred to our center. No history of any shortness of breath on exertion or any palpitation. No, he used to have medications for deworming routinely. No history of any pica. No history of intake of excessive cow's milk or intake of goat milk. No history of yellowish discoloration of eyes, red or cola-colored urine, black-colored stools. No history of abdominal distension. No history of any leg ulcers. No history of weakness of limbs, numbness, paresthesia, abnormal behavior, or any developmental delay. No history of decreased urine output or any generalized swelling. No history of breathlessness or any chest pain. No history of recurrent or any chronic diarrhea, vomiting, abdominal pain. No history of fever, cough. No history of any drug intake other than iron tablets. No history of any bleeding manifestations, weight loss, bone pain, recurrent infections. Past history. He was detected to have some hematological disorder at 5 years of age. It was incidentally detected from local hospital on evaluating for excessive tiredness. Then child was advised to start on oral iron for 3 months with improvement in clinical symptoms within a week and normalization of hemoglobin values after 3 months. So after 6 months of stoppage of iron therapy, child had recurrence of symptoms, and he consulted at local hospital Pala and was found to have a hemoglobin value of 4 gram per deciliter. Then child was restarted on oral iron therapy for 3 months after seeing the peripheral smear, which was consistent with features of iron deficiency. Hemoglobin values normalized after 3 months of iron therapy, and he was advised to stop the therapy. So at 6 years of age, at November 2019, he was detected to have a hemoglobin of 4 gram per deciliter. Again started on iron, and the repeat hemoglobin done after on December 2020, it was found to be 9.4 gram per deciliter. Then child was continued iron for 2 more months. Then child was taking medications from the ASHA workers during the COVID pandemic, and the child was asymptomatic for a period of almost 2 years. So at 8 years of age, when the child was off treatment, he got symptomatic again with the hemoglobin detected to have 4 gram per deciliter. And the iron studies were sent, which was said to be abnormal, and referred to our center after starting oral iron. So, but they didn't consult here and came here after 3 months of iron therapy, and hemoglobin and the other hematological parameters were found to be normal at the time of presentation. So he was kept at a follow-up on OP basis. So while on continuing on oral iron, they lost a follow-up and the iron therapy was stopped. So the next presentation was the current admission after 3 months of after 3 months of stopping therapy with the tiredness and paleness. And while on examining the child, it was informed that he was having some yellowish discoloration of eyes along with some organomegaly requiring inpatient care and further evaluation. So no history of any blood transfusions in the past, no history of any yellowish discoloration of eyes passing red urine or color-colored urine or any black-colored stool in the past, no history of any abdominal surgeries or any hospital admissions in the past, no recent history of any viral illnesses. Antenatal history, it's a second twin of non-consanguineous marriage, no history of any abortions, and they took regular ANC from Taluk Hospital, Nedungandam. And the first trimester, UPT positive after 4 weeks of amenorrhea, no history of any bleeding per vagina, fever with rash or any hyperemesis, folic acid and 2 doses of TT were taken. Second trimester, quickening felt at 4th month, history of UTI at 5th month, which was treated with oral antibiotics, anomaly scan done normal, calcium and iron tablets were taken, and no history of any gestation, diabetes, hypertension, bleeding or any leaking PV. Third trimester, the fetal movements were good, no history of any GDM, gestational hypertension, bleeding or leaking PV, and the growth scan done, which was found to be normal. At natal and postnatal history, it's a late preterm vaginal delivery in view of preterm pain at 36 weeks. The baby cried soon after birth, having a birth weight of 2 kg at Taluk Hospital, Nedungandam. The postnatal period was uneven full, no history of any neonatal hyperbilirubinemia, anemia, or any blood transfusion history, and the baby got discharged on postnatal day 3. Developmental history, no history of any developmental delays. Now child is studying in 4th standard with a good scholastic performance. Nutrition and dietetic history, he has exclusively breastfed till postnatal day 2, after which he was started on formula feeds, which was given for about 1 year of age. So the complementary feeding started with ragi after 6 months of age and family food diet at 1 year of age. Now child is on mixed diet, but deficit in vegetables, green leafy vegetables, egg, meat, and increased intake of black tea was present. So he is getting a calorie of 1180 with a deficit of 520 and protein of 37.75 grams. Immunization history is fully immunized up to age as per the national immunization schedule. And last vaccine taken at 5 years of age, no history of any adverse effect following immunization. Family history, no similar illness in the family. The other twin and the younger siblings were normal, and no history of any blood transfusions in the family, no history of any gallstones, abdominal surgeries, or in the family. Socioeconomic history, it's a 5-membered family, and father is the earning member, studied till 12th, and he's a carpenter. Mother studied up to degree, and he's a homemaker. And sanitary latrine was present, drinking water from the well. They belongs to lower middle class according to modified Kupaswamy socioeconomic class. General examination.
Now, wait. So we want to discuss the history. So what is the summary and what is the problem, exact problem in this child where we have to find the solution?
9-year-old child who is detected to have some anemia, hematological disorder at 5 years of age, now present on, which was improved on iron therapy, after which many years on off therapy, he presented with recurrence of complaints, and now presented with complaints of tiredness and paleness of 3-day duration when he was off treatment for 3 months.
So what do you think the problem? The recent episode, pallor and
recent episode, child is having pallor.
Again, pallor only. So for the last 4 years, child was getting recurrent pallor. Is it not? And is it very common to recur iron deficiency anemia?
Chronic blood loss, if the dietary intake is a deficit, child is having.
Okay, so causes of, most common cause of anemia at high years of age, which is the most common cause.
So nutritional anemia is most
nutritional
common.
anemia. Among the nutritional anemia, which one?
Iron deficiency anemia is the most common.
What are the other nutritional anemias?
Megaloblastic anemia.
Due to?
Toxic deficiency can occur.
Megaloblastic anemia due to what?
Vitamin B12 deficiency as well as folate deficiency.
Folate deficiency. Okay. So, and with iron therapy, child improved.
Yes, madam. Child improved.
According to the history, by iron therapy, even at hemoglobin 4, child was treated with iron and child improved, and the hemoglobin became 12 according to the history.
Yes, madam.
Okay. So why the iron deficiency is recurring? If it is iron deficiency.
Maybe child is having some occult blood loss, chronic blood loss.
Okay.
Uh,
Chronic blood loss you get in which are the conditions you get chronic blood loss?
celiac screw, Meckel's diverticulum, any
Mm.
telangiectasias,
Mm.
polyps, intestinal polyps,
Mm.
cow's milk protein allergy that leading to
Mm.
colitis,
Okay.
parasitic infestations with worm infestations.
Mm. So any of these are present? Is it a celiac disease?
Madam?
Is it a celiac disease history-wise?
No, madam. Child is having adequate growth and no recurrent history of any abdominal pain or any GI symptoms,
Hmm.
and no growth parameters within normal.
Okay. Is there any black colored stool?
No history suggestive of any chronic gross blood loss, no black colored stools.
Okay.
Normally passing urine, no hemature, red colored urine or cola colored urine.
Okay. So you are going to stick on the diagnosis iron deficiency in this time.
Yes, madam.
Yes.
Yes, madam.
Okay. Then go on to examination.
Examination, child was alert, interacting with mother. Severe pallor was present, bilateral palmar pallor, and a mild distress. No edema, cyanosis, clubbing, or lymphadenopathy. And vitals, pulse rate, it was 112 beats per minute over the right radial artery. Regular rhythm, a high volume pulse, normal character, no radiofemoral delay, and all peripheral pulses were felt equally and bilaterally. Respiratory rate was 22 breaths per minute. It's an abdominal thoracic type. The blood pressure 100/60 millimeter of mercury between 50th and 19th centile. No hypertension. It's in right arm in the sitting position. Temperature 98.2 degree Fahrenheit normal. SpO2 98% in room air and CRT less than 2 seconds. Head to foot examination. Head normal. Head size is normal and shape. No facial dysmorphism. No frontal bossing, malar prominence, or any depressed nasal bridge suggestive of any hemolytic phases. Icterus was present and tail, lower palpebral conjunctiva, tongue, oral mucosa, and the both palmar creases. Oral cavity, no gum bleeds or any palatal petechiae, no glossitis or angular cheilitis, no skin bleeds, abdomen, no distension or any surgical scars, no nail and skin changes, no koilonychia, no evidence of any hyperpigmentation of knuckles, no leg ulcers or any bone tenderness, no limb anomalies. Anthropometry, weight is 24 kg with an expected of 28 kg. It is between -1 and -2 standard deviation according to WHO. Inference is no malnutrition. Height is 135 centimeter with an expected of 132 centimeter between 0 and +1 standard deviation according to WHO. No stunting. And BMI is 13.1 kilogram per meter square with an expected of 16 kilogram per meter square at 5th centile. It's normal. Systemic examination, gastrointestinal system, examination of upper GIT, oral cavity, pale oral mucosa and tongue, good oral hygiene was maintained. Examination of abdomen, inspection, abdomen not distended, umbilicus central and inverted, all quadrants move equally with respiration, no scars, dilated veins, visible pulsations, hernia orifice is normal, and external genitalia also normal. Palpation, abdomen is soft and non-tender, no local rise of temperature. Liver palpable 3 centimeter below the right coastal margin in the midclavicular line, which is having a soft consistency, smooth surface, rounded margin and non-tender. Spleen palpable 2 centimeter below the left coastal margin, soft consistency and non-tender. On percussion, liver span 10 centimeter with no free fluid and drop space was dull. Auscultation, bowel sounds were heard normally, no renal, hepatic or aortic bruit or venous. Cardiovascular system, pulse rate 112 beats per minute over right radial artery, regular rhythm, high volume pulse, normal character, no radiofemoral delay, peripheral pulses were felt equally and bilaterally, and BP was 100/60 millimeter of mercury in the right arm in sitting position. Shape of the precordium normal, no visible pulsations, apex felt at left fifth intercostal space at midclavicular line, cardiac board is percussed out normally, heart sounds first and second heart normally with the grade 2 systolic murmur best at the pulmonary area. Respiratory system, trachea was central, chest movements were bilaterally equal, percussions, a resonant note is heard in all auscultatory areas, Normal vesicular blood sounds in all auscultatory areas, no added sounds. Nervous system examination, higher mental functions was normal. Cranial nerves examination normal. Motor system, the tone, bulk, and power was normal. Sensory system was normal. Reflexes all superficial and dependent reflexes present bilaterally. No abnormal movements, no signs of meningeal irritations. Skull and spine was normal. Summary. A 9-year-old boy, developmentally normal, immunized for age, no past history of any blood transfusions. With now history suggestive of iron deficiency anemia, detected since 5 years of age, on oral iron therapy, on and off since then. Now showing improvement while on iron therapy. Now presented with complaints of tiredness and pallor for 3 days while the child was off treatment for 3 months duration. On examination, severe pallor was present with a mild distress, vital stable except for a high volume pulse. Head-to-foot examination, no hemolytic phases. Systemic examination, mild soft hepatitis splenomegaly was present with a grade 2 hemic murmur. No other signs of cardiac failure. The diagnosis, severe anemia, iron deficiency anemia with a hemolytic anemia with no signs of cardiac failure. And the probable differential diagnosis, it could be thalassemia trait, enzymopathy, and membranopathy, hemoglobin H disease or paroxysmal nocturnal hemoglobinuria.
So why you directly jump into diagnosis of hemolytic anemia?
Madam?
What are the other possibilities? This is for the last 4 years. Child was on iron whenever he developed anemia and child improves. And now on examination, there is hepatosplenomegaly jaundice.
Hepatitis splenomegaly and mild
Is it common iron deficiency anemia coexisting with hemolytic anemia?
It may be because of hemolytic anemia or maybe because of an underlying
Is it common? Is it common? Hemolytic anemia, iron deficiency. Actually, in hemolytic anemia, the classical teaching is we should not give iron because there is no loss of iron from the body. It is reutilized. The RBC undergo hemolysis and iron is reutilized. So is it common iron deficiency anemia in a case of hemolytic anemia?
Not common.
Not at all common. Not common, not at all common. So think of other possibilities. Is it a single disease or a multiple disease? Yes, Chinu?
Yes, madam.
You directly jumped into hemolytic anemia just because of mild jaundice and the hemoglobin level is 4 grams this time. If it is due to hemolytic anemia and the hemoglobin is 4, we expect more jaundice most often. Yeah.
Then HB4 in hemolysis, much more jaundice will be present. Child is having only mild distress.
Mild distress. So you consider one disease or multiple disease. Already a known case of iron deficiency anemia, developing some other problem and present with jaundice.
Maybe a child on iron deficiency and not having an iron deficiency anemia might having an underlying congenital hemolytic anemia, or maybe because of some viral illness causing acute hemolysis.
Acute hemolysis. Okay, that means autoimmune.
Autoimmune hemolysis.
Then
Acquired conditions, it may be because of any enzyme deficiencies.
Repeated treatment, injections, testing, and now the child is presenting with jaundice. And entirely different condition can coexist. Just for asking, we have to think. I am not saying that. Can it be a pure hepatic problem?
Wilson's disease can present with hemolytic anemia.
Yes, Wilson disease can present with the. So what is the cause of hemolysis in Wilson disease?
Copper deposition causes RBC breakdown.
Yes. So when there is excess release of copper into the circulation, it can sometimes produce hemolysis. Then entirely different, not related to iron deficiency or anemia. Can
Now,
we
the
be
child may be presented with any acute hepatitis infection.
acute hepatitis? So you have to roll out that one also, any hepatic recent problems due to infection or a condition like Wilson disease. Okay. So what's the problem? There is a production problem,
As well as a
and
destruction
at
problem.
the same time, there is a destruction problem. So really confusing. Usually both will not occur together. So this is a case of difficult anemia. Coexisting production problem as well as evidence of hemolysis. Clinical evidence, that is jaundice and hepatosplenomegaly, may be due to hemolysis or may be due to other disorders of liver. Okay, so go on to investigation. We have to find out whether it is a production problem or a destruction problem. So what is the approach?
So, child admitted here, and we investigated to rule out the causes of hemolytic anemia. So there should be a complete blood count done, which shows an hemoglobin of 3.4 gram per deciliter, suggestive of severe anemia. Hematocrit was 14.8%. Mean corpuscular volume is 66.1, which is microcytic, and MCH and MCHC 15.2 and 23. Hypochromic picture. RBC is 2.24, RDWCV is 21.6. This elevated anisopoikilocytosis is indicating. The Menser index is 29.5%. Other cell lines, platelet, and the total count were within normal limit.
So from this, what is the inference? There is anemia, and it is what type according to the morphology?
It is a microcytic hypochromic anemia.
Okay.
With the anisopoikilocytosis as RDW is elevated.
Okay. So how will you evaluate microcytic? What are the causes of microcytic anemia?
Microcytic anemia.
How will you classify?
Iron deficiency anemia, thalassemia, alpha beta thalassemia, other HBEC diseases, pyropoikilocytosis, sideroblastic anemia, lead intoxication, and refractory iron deficiency anemia.
Then malignancies, sometimes myeloproliferative disorders.
Anemia of chronic disease initially have microcytic.
But sometimes it can lead to, microcytic. So how will you proceed? So this is hyperchromic microcytic anemia with anisopoikilocytosis. Okay, so
clinical evidence of hemolysis, we further investigate to look for retic count, which was 9.7%. It was an elevated with a corrected retic count of 3.2%. And the peripheral smear done, it shows a microcytic hypochromic anemia with a few polychromatic cells noted. The WBC count within normal with a relative increase in neutrophils, and a few hypersegmented neutrophils was noted, platelet within normal limit. LDH was done, it is 430, elevated. The direct Coombs test done, it was negative.
what it indicates? Retic count is 9.7 and corrected retic count is 3.5. All these indicate what?
It indicates reticulocytosis, which means effective erythropoiesis is happening.
Yes. Then
it is actually an evidence of hemolysis.
Hemolysis. Then peripheral smear, is there any evidence of hemolysis?
Polychromatic cells was present. Which
So that also.
cells.
And what about LDH?
LDH was elevated 430.
430. So here, that indicates a hemolytic process is going on. Is it not? Hello?
Hello, madam.
No.
Yes, madam.
So how will you proceed? What about, is there a true iron deficiency? What about the iron studies?
Iron studies done. Serum iron was 24. It was normal. Total iron binding capacity is 341. It's also normal. The serum ferritin, it is 80.2. It is normal. And the transferrin saturation is 7%, which is suggestive of iron deficiency. It is less than 16%.
So is it always like that? Why serum iron is, all the other are serum iron is 24, serum ferritin is this much. Hmm?
Madam?
Is it completely support iron deficiency?
No, madam. Only
No.
transferrin saturation is only suggestive of iron deficiency.
Only suggestive.
The other
Serum ferritin
parameters
is
in iron studies was normal. It is not.
normal. So it is not a simple case of iron deficiency. Is it not?
Yes, madam. Not a simple.
Do you still stick on to your nutrition deficiency of iron?
No child is having nutritional deficiency along with some hemolytic process underlying. Could be because of acquired or any congenital.
Okay. Then how will you proceed? What is the reason for iron deficiency? Evaluation shows
Chronic blood loss.
there is no blood loss. 3 days to
3
local
days to
blood.
local plus was negative.
Then other.
Then we, the other causes were also ruled out. Malarial parasite evidence, that's also negative. IgM mycoplasma, no evidence of any hemolysis, it's also negative.
Then
So suspect
I look
other
for-
hemolytic process.
hmm,
We further evaluated and hemoglobinopathies was ruled out by doing HPLC. It was also normal, not detected any abnormal hemoglobins. The sickling test done, it was also negative. So folate and iron vitamin B12 levels are also normal.
Okay, so what is your inference? You have ruled out all the thalassemias. Have you ruled out?
HPLC was normal, madam. It's not commented any abnormal presence of any abnormal hemoglobins.
Then have you got the answer? The cause, real cause of anemia in this patient after the investigation? Or which is the hemolytic anemia where iron deficiency can occur?
Paroxysmal nocturnal hemoglobinuria is a one which having a coexistence iron deficiency anemia with the hemolytic anemia.
That is the only condition where you can give iron. All other hemolytic anemia, iron therapy is contraindicated. So, have you looked for that?
Yes, madam.
So, what is the result?
Negative.
It is negative.
Urine, that's negative. And definite diagnosis test is flow cytometry for the CD55 and 59. That was also done, but it was found to be negative.
So, PND panel was done and that is found to be negative. So, that's out. Then, what do you think the problem is? So, this is a case of difficult anemia. Production problem, destruction problem, hepatosplenomegaly is there, jaundice is there. So, in difficult cases, what are the situations, clinical conditions you have to rule out?
Rare cases like sideroblastic anemia, myelofibrosis, myelodysplastic syndrome, head toxicity.
So, among these, which will produce microcytic anemia? You have ruled out Wilson also. Serum copper normal
Ceruloplasmin is also normal.
and 24-hour copper excretion.
24-hour urine copper was advised to the patient, but actually they were not done. So
Dama. It was not done. So we have to do that also. Penicillamine challenge test we have to do. And have you looked for in KF slit lamp examination?
slit lamp examination will be done an ophthalmological evaluation to rule out the presence of KF-ring. It was absent.
Absent. Okay. So 24-hour copper excretion also has to be done following penicillamine challenge. Then what are the other microcytic anemias?
Other rare microcytic anemias, sideroblastic anemia, anemia of any chronic illness or any infections, myelodysplastic syndrome.
So how can you diagnose that condition?
Bone marrow.
Bone marrow study. So bone marrow, what are the picture you will get in all these conditions?
Hemolytic anemia.
Bone
Sideroblastic.
marrow. You said some
Sideroblasts will be present.
causes for difficult anemia.
Sideroblastic anemia, bone marrow.
Erythropoietic anemia, sideroblastic anemia, myeloproliferative disorders, myelodysplastic syndrome, myelofibrosis. Lot of conditions are there which can present with anemia. Troublesome. So what are the findings you will get in bone marrow? Usually hemolytic anemia bone marrow is not indicated. When there is no answer or we are not getting an etiology and investigations are suggestive of hemolysis and hemoglobin electrophoresis, HPLC, all are negative, then bone marrow is indicated. So what are the findings you expect in each condition?
In sideroblastic anemia, we will get ring sideroblast. Myelodysplasia will be dysplasia of the bone marrow. So, pancytopenia will be present.
So this is only one cell line is involved.
Yes, ma'am.
No platelet abnormality, no
platelets
WBC
and
abnormality.
total convar within
Only single line. So myelodysplastic syndrome usually multi-lineage problem. Yes. So what are the findings? So what are the findings you expect? And what stain should be done?
All staining in case of sideroblastic anemia. Will get ring sideroblast when staining with the Prussian.
So you have to ask specifically for doing Prussian blue staining. Otherwise, you may not diagnose that condition. What is it really due to sideroblastic anemia?
It's actually because of defective in heme synthesis. So that the mitochondrial iron get deposited in the perinuclear fashion. So when staining with the Prussian blue, this gets stained in the form of ring appearance. It is actually known as ring sideroblast.
Actually, it is integration of iron with the mitochondria is affected. So the hemosiderin pigments are deposited around the nucleus, perinuclear
mitochondrial iron.
So what are the different types of? Can I produce hepatosplenomegaly and jaundice?
No, it can cause iron overload.
Can sideroblastic anemia, there can be hepatosplenomegaly and jaundice.
Hepatosplenomegaly can be.
Okay. It can occur. Hepatomegaly, mild splenomegaly, and hemolysis can occur. Yes. Then there are different types of sideroblastic anemia, type 1, type 2, type 3, according to the sideroblast and distribution of the hemosiderin pigments around the nucleus or throughout the cytoplasm. Then what about other condition?
Myelodysplastic syndrome, myelofibrosis, lead intoxication.
So lead intoxication, do you think whether this child is having pica?
No, madam. No history of
No,
any
madam.
pica.
So what is the blood level of lead?
If it is more than 10 microgram per deciliter, the suggestive of
Lead poisoning.
poison.
It is a notable disease. Actually, we have to do all those also in order to exclude one cause of microcytic anemia. Then, so what is your impression after this? Again, by hemoglobin electrophoresis, which are the conditions you can rule out?
Alpha beta thalassemia, sickle cell anemia.
Only that?
Persistence of hemoglobin F syndrome.
Only that? You can detect hemoglobin C disease, hemoglobin E disease, hemoglobin S, sickle cell, then hemoglobin H. So that is alpha thalassemia. But can you rule out alpha thalassemia from a case of hemoglobin electrophoresis? Not always, because alpha thalassemia and beta thalassemia patterns merge together, almost the same density, same travel time. So, which are the most common microcytic anemia apart from iron deficiency?
Thalassemia.
That can present as iron deficiency anemia most often, mistaken as iron deficiency.
Beta thalassemia. Thalassemia trait.
Beta thalassemia trait and alpha thalassemia trait. Both are there. Alpha thalassemia trait and beta thalassemia trait. So how will you exclude beta thalassemia?
Beta thalassemia trait, while doing HbA1c, there could be elevated levels of HbA2 level.
So HbA2 will increase and HbF also will increase, elevated in beta thalassemia. So, is there a simple dietary deficiency in this case or any disorders of iron metabolism?
Maybe associated
That also we have to discuss. Usually our idea is when iron deficiency, it is due to nutritional deficiency. Apart from nutritional deficiency, iron deficiency can occur in our body due to what?
Defective absorption, transport, cycling.
Yes. Yes, go on. So a lot of disorders are there due to inborn errors of metabolism in iron transport, iron integration, iron absorption due to enzymatic deficiency. Due to enzymatic deficiency. So what is the evidence? Can you evaluate? Because this is a case of difficult microcytic hypochromic anemia, we have to think of that also. Hello?
Madam.
Is anybody there?
Yes, madam.
Yes. Rahul, can you say?
Yes, madam.
Can you contribute?
Look at the
Other test to
scientific
assess?
level.
Yes. Yes. Most
Iron.
common test to assess the iron metabolism.
Cytochrome levels.
Erythrocyte zinc protoporphyrin. That is the enzyme for the first step in iron metabolism at the mitochondrial level. So at least we can, that facility is there. Erythrocyte zinc protoporphyrin. Then for a continued loss, any Meckel's? How will you exclude Meckel's? Hello?
Chronic blood loss will be there.
The common presentation of Meckel's is massive GI bleed. But sometimes it may present with a chronic blood loss and abdominal pain. And abdominal pain is lacking in this patient. Is it not? Still, you have to exclude. How? Which investigation? Occult blood loss positive means so many reasons are there. Inflammatory bowel disease, sperm infestation, cow's milk allergies, lot of conditions are there. So in order to exclude Meckel's, Meckel's scan is there.
Technician 99.
Yes. Is there any intravascular hemolysis this time?
Urine hemoglobin then was negative. But other intravascular hemolysis suggests hemoglobinemia, hemosideruria.
Plasma hemoglobin will increase. Then urine.
Hemoglobin urea will be there. And hemosideruria.
Have you done that?
No, madam. Only done urine hemoglobin.
That is negative. Is it negative?
Urine hemoglobin, then it was negative.
Have you done osmotic fragility?
Osmotic fragility, incubated, 24-hour incubated osmotic fragility is done. Actually, RBCs are exposed to a hypotonic, decrease in concentration of hypotonic saline. Observed for the evidence of hemolysis. If there is increased hemolysis, shift of flow towards the left side will be present. In case of spirocytes, elliptocytes.
Can you tell the approach towards a microcytic anemia with increased reticulocyte? The flow chart.
actually flow chart across hypercytic anemia. Initially, go with rectal. If that is found to be increased, we do iron study. If that suggestive, if it is decreased, that is suggestive of iron deficiency anemia. If the iron studies are normal or increased, go with the hemolytic parameters like bilirubin, LDH, haptoglobin, hemoglobin electrophoresis. That is positive for electrophoresis. It may be because of beta thalassemia, major, intermediate, or trait, HBC disease, and rarely it could be HBE, HBD disease, HBH disease. If that it's negative for electrophoresis, then look for the poikilocytes in the peripheral smear. If that is positive, it could be a hereditary pyropoikilocytosis. If the smear is negative for poikilocytes, go for elliptocytes. If that is positive, suggestive of hereditary elliptocytosis. If no evidence of any elliptocytosis, work for paroxysmal nocturnal hemoglobinuria or any erythropoietic porphyria. If the retic count is decreased or not increased, again we go with iron studies. If that is decreased, it is suggestive of iron deficiency anemia. If it is normal or increased, hemoglobin electrophoresis could be done. If that is abnormal, it is hemoglobinopathy. If it is normal, assess for alpha thalassemia, HBH preparation plus or minus molecular study. If that is positive, it could be alpha thalassemia. If negative for molecular studies, dual population study along with the Pappenheimer body staining on peripheral smear. If that is positive, bone marrow could be done to rule out the evidence of sideroblastic anemia. If it is negative, presence of coarse basophilic stippling was present, then it could be because of a lead toxicity. If that is also negative, then it could be anemia of chronic disease if inflammatory markers are suggestive.
Okay, have you got answer at the end of history and examination findings and after investigation so far?
Severe anemia, it might be an iron deficiency because child responded towards iron along with some underlying hemolytic evidence. It may be because of congenital or acute presentation.
Okay, any other opinion from audience? All right, PGs. Hello? Any other opinion? PGs? പുരുഷോത്തമ സാർക്ക് പോയോ?
ഇല്ല ഇവിടെ ഇവിടെ ഉണ്ട് ഇവിടെ ഉണ്ട്.
ഒന്ന് പറഞ്ഞോളൂ. So really really interesting at the same time difficult. എനിക്ക് ബ്രോങ്കൈറ്റിസ് ലാരിഞ്ചൈറ്റിസ് പിടിച്ചത് കാരണം സംസാരിക്കാൻ ബുദ്ധിമുട്ട്. ഭയങ്കര ഡിസ്റ്റർബൻസ്. സ്ട്രെയിൻ ചെയ്ത് പറയണം. Difficult anemia, അല്ലേ? So bone marrow will give an answer, I think. Iron deficiency anemia, but serum iron is normal. Instead of that, towards serum ferritin is also normal. Hemoglobin 4 gram. If it is due to iron deficiency, we expect serum ferritin less than 12. Instead, the serum ferritin is 79. Peripheral smear shows some evidence of hemolysis. LDH is increased. So, what do you think? My feeling is that by doing bone marrow, we will get an answer. Sideroblastic anemia, Prussian blue staining has to be done. Myelofibrosis, reticulin staining has to be done. Otherwise, you will not get bone marrow normal nor needle. Myelodysplastic syndrome in the early stage it can. And sideroblastic anemia, what are the causes? സാറേ എന്ത് അഡീഷൻ ഉണ്ടോ?
Purushothaman sir, is there any comment from your side? Because we are
മാഡത്തിന്റെ ശബ്ദം ക്ലിയർ അല്ലാത്തതുകൊണ്ട് മനസ്സിലാവുന്നില്ല, അതാണ് ഉണ്ടായിരുന്നത്. Chinno, you didn't mention about the details of the other twin, because two things are very, very important in this case. About the other twin and then the asymptomatic period up to 5 years. These 2 points are very important in this case, because whether the other twin is of the same sex or other sex.
Same sex, sir.
Same sex. That's very, very, very important, because the genetic problems, if any of these things, almost concordance for any of these things around 50 to 60%. So that child was perfectly healthy till now.
Yes,
That is a very, very important point. The two things, when the twin is the genetic problems are less likely. Second thing is environmental, the nutrition also, they are sharing the same environment. So those 2 points are very important. So child was asymptomatic up to 5 years. That again point towards something other than something acquired, because even when it is a hemolytic anemia, thalassemia, minor, many of the other rare things in the DD you consider, why it was asymptomatic up to 5 years. So if you diagrammatically write the whole picture, up to 5 years normal, then symptomatic waxing and waning responding to iron. So overall diagrammatic picture is like that. So something which is responding to iron. If it is again a hemolytic anemia, by this time iron overload, everything will be there. So most likely this time bilirubin, the jaundice, you didn't mention about the bilirubin and LFT. That is important, because it can be totally unrelated, as you said. The spleen tip is soft and the liver is soft. So this time only there is a hemolysis. That's possible. So you need to tell about the previous peripheral smear and details of any hemolysis noted earlier. Is it this particular hemolysis occurred during this time only? Or that's possible in a folic acid deficiency or a hepatitis or something. So acquired short duration, one episode of hemolysis may be the only thing. The rest of the thing may be microcytic hyperchromic anemia itself, but microcytic hyperchromic anemia less likely to be a nutritional. There may be a missing bleed. Madam already discussed the possibility of Meckel's diverticulum is high in this list. Rather than going for the rarer DDs like sideroblastic anemia, we need to consider common things, always common, because after the nutrition, second thing is the blood loss. Occult blood test is not a major point to rule out bleeding, blood loss. So blood loss is high in the list, and an occult blood loss like Meckel's diverticulum high in the list. The other DDs you need to consider, of course, the copper deficiency you rolled out, pyridoxine deficiency, lead poisoning. So all these things are also to be considered. One point in the basic thing, the measurements you said, the height is normal. So that again is a little unusual for a chronic hemolytic situations and the nutritional problems. Then you said it's about BMI. A child whose weight is on the lower side, there you should have mentioned about wasting rather than BMI. And in the nutritional intake, you said it is 16 grams of requirement. It's not 16 grams of protein. So some of these slides you need to be careful when you're presenting. The requirement 33 is the intake, and the expected is 16. That's what you said. And the measurement part, you mentioned BMI, where the child's weight is low. So all these things are important. I feel rather than going for the rarer things, most likely we may be missing an occult blood loss, and that is responsible for the response to the iron again and again coming back to normal. So in any case of hypochromic microcytic anemia, you need to answer 1, 2, 3, 4, 5, 6. First thing, am I right in the diagnosis? Is it something else? Second thing, nutrition anemia, is it iron or without the dimorphic possibilities? Maybe you're missing folic acid. So another thing, are you giving iron only or iron plus folic acid? Because in a situation like this, there can be a response to iron plus folic acid is responding not to the iron, but to the folic acid. So all these things, minute things you need to mention. The right choice of the drug, the dosage of the drug, the compliance of this thing. And of course, there is some other thing like lead poisoning. There is some other thing like continuing bleeding. All these things are important. I feel the bone marrow most likely been in the iron deficiency only most likely. Sideroblastic and other things are less likely, I think. And you said about the dyserythropoietic anemia and all. Most of the situations, there will be genetic and the other features of dysmorphism are likely in this case. Thank
So
you.
we expect bone marrow to be abnormal. Okay, thank you, Dr. Purushottam. Anybody? Any additions? Suresh?
No, madam. No, madam.
No,
Shanavas sir is there. Shanavas sir, you want to
sir.
add anything more?
Fine.
Shanavas sir and Cyril sir are there. Cyril sir. Cyril sir, are you there?
Yes, I'm
Any
here.
suggestions for investigating this case further? Any new thoughts? Sir, you can tell. Cyril sir.
No, initially I was thinking that it may be a thalassemia trait or like that, but the test was negative. Sometimes there may be a combination of iron deficiency anemia as well as this, but the test was negative. So I don't have anything new in that to add.
Okay, നമുക്ക് സ്റ്റോപ്പ് ചെയ്യാം സുരേഷ്.
We have gone for a detailed investigation anyway. Gigi madam, you want to have any final comments regarding this case?
Good evening. Actually, we have done an LFT for this child. The enzymes are normal for this child. And bilirubin is slightly elevated, sir, 3.2. Purushottam sir, it is 3.2. Then unconjugated hyperbilirubinemia. And then we have done serum folic acid and vitamin B12, and that was found to be normal. And these are the investigations which are done when we are suspecting why the child was having jaundice.
One investigation which I would like to do, because we should be doing the scatterogram, because there are few points in the six-part automation nowadays is available. Few things in the reticulocyte, early reticulocyte fraction, reticulocyte hemoglobin, all this can be there in a six-part automation. So those are latest investigations which may be helpful for the other. And of course, the nucleotide imaging is to be done to rule out, because occult blood per se is not enough.
So another thought I have is that, sir, except for this present last episode of jaundice, all the time it was a iron responsive anemia. It was responding well to it. And why the iron deficiency is becoming resistant or recurring over a period. One point sir said is that you have blood loss, you have to carefully evaluate for some blood loss. So any transporter mechanism or a regulator mechanism that can be involved in this issue, some genetic conditions like that. Like something like madam was telling, iron transport and iron absorption defects may be possible, which can lead to this when you give iron at its market.
At transferemia, we had one case proved in Thrissur. A transferemia, congenital transferemia was there. But that's a very rare entity. And of course, in this case, other girl child twin is perfectly normal. That is again one point.
You are not sure whether it's a monozygote or a dizygotic twin like that.
Yes, agree.
Something related to hepcidin and all those things are again involved in the very rarity of the cases, because this thing is happening like this over years. It is like that, and some kind of deficiency responding to it. That's what I have a thought about all this. So Anwar sir, are you back?
There was a shift to right in the periparosmia.
Any other comment?
Chino, use in the periparosmia, there was a shift to right. Five segmented neutrophils were there. That's what you mentioned in the periparosmia.
That was not more than hypersegmented polymorphs means more than 5 logs. Dillalo.
They actually commented as few hypersegmented neutrophils.
It was
Pathologist in there. Only few. So that we can take in favor of polychromasia. Polychromasia is the general picture you get in hemolytic anemia in the peripheral smear.
The previous smear always need to be checked in this case, because there is a possibility of both liver dysfunction or this time only hemolysis. So that is because many times she was admitted, you will be having record of the peripheral smear. Whether that the polychromasia was mentioned in the previous peripheral smear is very important. Is it this
No,
time?
sir, nothing mentioned. They
Yes.
commented as microcytic hypochromic anemia with anisoprotein.
Yes, because the liver is soft and the spleen is very small. There's every chance that this is a new episode, unrelated.
Most probably. Any other postgraduates who want to contribute anything, or you want to ask any question? So, as Madam said, we will wait for the bone marrow report to come.
Yes, yes.
We are planning for a bone
Next
marrow.
investigation that should be done is bone marrow. If the bone marrow shows, you can diagnose iron deficiency anemia by Prussian blue staining, and other rare disorders also you can diagnose by bone marrow. So after that, we will. If it is normal, look for chronic blood loss like Meckel's diverticulum.
Okay. So we request Chinnu to update us in one of the coming sessions if you have the bone marrow results with you, to know what happened this time. Okay. There are no more questions. We'll wind up the session. I take this opportunity to thank Savitha Madam for taking pain with her ill health and bronchitis issues to conduct this session nicely. And I congratulate Chinnu for presenting the case in a very vibrant manner. And Chinnu was very fast in presenting the case. I was a bit lagging to attend to that. What are the points that are being given? Before we end, Darling Madam, you want to say anything? You are muted. You are muted. Madam, muted. Darling Madam, muted.
Yes,
Madam,
Chinnu's presentation was excellent. And without any other person's help, she presented very well. Actually, no other PGs were helping her, I think, with answers and all. And Gigi, for your excellent mentorship.
Thank you, madam.
Actually, Gigi Madam has extensively worked up the case, and that also helped us. And we will wait for the bone marrow results. So,
okay.
Thank you all. Thank you, Purushottam sir, for your inputs. Thank you, Hanu sir and Cyril sir, for joining us. Thank you all the postgraduates.
Yes, one word. This is the first time we are doing a discussion without the final diagnosis, a pending diagnosis. That's a good thing, because that leaves a lot of chance for discussion.
Yes, yes, that's true.
Maybe we are all waiting for the Chinnu's report in the next session. Maybe we can continue this sort of a discussion in the coming sessions also, Jose. Shanbasa.
Madam, your discussion was also very nice. I didn't tell about Savita madam. Thank you, madam.
Okay.
Okay, so we'll wind up the session. Thank you. Thanks a lot.
Joseph Oyo.
Right. Joseph, yeah.
Okay, sir.
Sabila.
I'm ending the session.
Manu, we can conclude the session. Manu,
Okay,
we can conclude the session.
Okay, sir. Okay, sir. I'm
Okay.
ending the session. Thank you all.
Bye.
Thank you, madam. Thank you, sir.
Thank you all. Good night.
Good night.
Bye.
Madam, നന്നായിരുന്നു madam. ഇതുപോലെ ലാരിഞ്ചൈറ്റിസിന് വരട്ടെ madam.